एप्लीकेशन है, रिक्वेस्ट है।
हाँ,
कल पॉसिबल हो पहले वाले में किसी में एडजस्ट करना है कि हमको शाम को बहुत अर्जेंट हमारे फ्रेंड की बेटी की शादी का है।
ये इस वाले में कर दे, सेशन 4 में, इसके बाद वाले में
जिसमें भी कर दो, वेरी वेरी
5 बजे पहले खाली हो जाएंगे आप।
ठीक ठीक
ठीक। Good afternoon. As we are running late 30 minutes, so without much wasting time, I am inviting the chairperson for session 3, Dr. Mohit Saxena. He is a renowned cardiac surgeon from Varanasi. Please come on the desk. Dr. Rajiv Gupta sir, I think he is not here. Professor Sanjay Kumar sir, he is the head cardiothoracic surgery, IMS BHU. Dr. Vivekanand, please come on the desk.
Good afternoon, everyone. Thank you, Dr. Alok. So we'll be starting the session 3 without much of delay. So the first topic for the session 3 is a segmental approach to congenital heart disease. The speaker is Dr. Ashutosh Marwah. He's a director pediatric cardiologist at Scott Fortis Heart Hospital, New Delhi. So welcome, Dr. Ashutosh Marwah. Please.
Good afternoon, everyone. Yep. And thank you, organizers, for inviting me to this gathering. This is my second time in this heart conclave, and I'm really honored to be part of this gathering here. So, I've been given the topic of sequential segmental approach to congenital heart disease. Well, why? Why sequential approach? Why not just you can have a ASD, VSD? No, unlike adult, I guess most of people here are practicing adult cardiology. Very few will be doing congenital heart disease, looking after patients with congenital heart disease. So for us, the heart doesn't come as the picture book heart where you have 2 atria, 2 ventricles, and 2 blood vessels all arising in their normal positions. We have all sorts of malformation where one part may be underdeveloped or may be wrongly connected. So hence we need to have a proper approach so that we can give a proper diagnosis to the patient. So this is the method of identifying individual cardiac structures in terms of their intrinsic morphology, feature which is unique to that particular structure rather than in relation to any other cardiac structure which it might itself be variable. So it is called a morphological method. For example, just an example, like if you say patient has 2 atria, one left and one right, so pulmonary veins are draining into the left-sided atrium, but is the pulmonary vein a fixed feature? So answer is no. Pulmonary veins is a variable feature. IVC to a certain extent may be a fixed feature for right atrium. SVC again remains a variable feature because SVC may be draining into the coronary sinus or the patient may be having 2 SVCs. So we cannot define atria by its connection. Similarly, right atrium cannot be defined because it opens through a tricuspid valve into the right ventricle. It may be opening by a mitral valve into the left ventricle in a corrected transposition. So we have to have unique features for each structure before we label it as this is this. So, for example, I'll just give some examples. Left ventricle is identified by its smooth trabeculations, whereas the right ventricle has coarse trabeculations and a moderator band. Structures which are more or less fixed, and even when the chamber is hypoplastic, we may be able to identify the particular chamber by its unique morphology. mitral valve has a septophobic attachments, whereas the tricuspid valve has a septophilic attachments. They have offsetting, which I'll come to later. Similarly, great vessels, aorta. What is aorta? Now, aorta is one vessel which has at least one coronary artery and multiple systemic artery branches. Why at least one? Because L-kappa does exist. Similarly, pulmonary arteries, at least one branch pulmonary artery, because one may be absent, agenetic or ectopic. So one has to have unique features which identify this structure, and accordingly we reach a diagnosis or a conclusion. So we needed this kind of analysis to have, to remove any ambiguity in our communication, because what we are going to say to the surgeon or to the family should be one language, and it has to have a uniformity in communication, so that across the panel, say across, if I have to communicate with another cardiologist, I should be able to communicate in an unambiguous manner. And it also provides a complete picture, planning of treatment and prognostication. I just want you to focus at this. Is this pointer working? No. Okay, I think it's working now. Yeah. If you look at these two pictures, these two patients are cyanotic. Here, what we see is left ventricle to pulmonary artery and right ventricle to aorta. This is a very common transposition, as we would say, because the left ventricle to connected to pulmonary artery and right ventricle to aorta is a cyanotic heart disease, a transposition of great vessels. But look at this picture, right atrium, left ventricle giving rise to LVOT to aorta. So this is isolated AV discordance. So until unless we have identified the structures properly in their arrangement, we will not be able to do treatment properly, because treatment over here is an arterial switch, whereas treatment over here will not be arterial switch, because if you do an arterial switch, you will put aorta in the right ventricle, which should not be the case. So here the treatment will be a Senning repair. So that is how things change when we have the correct diagnosis, because our treatment changed. So for ease, the heart may be divided into three major segments: the atria, the ventricle, and the great arteries. But besides this, we have atrioventricular junction, the ventricular-arterial junction, and also the attachments of systemic and pulmonary veins. All segments can occur in various permutation and combination in a patient with congenital heart disease. They may be deformed to an extent that they may be unidentifiable, or they may not be in their regular position. Hence, we have to follow each of the cardiac segment, identify its own fixed feature, and interpret it in the manner that it is uniformly understood and replicated universally. And development of sequential segmental analysis has to a certain extent followed the echocardiography. So, most important and most crucial step for a pediatric cardiologist begins with identification of situs. So situs is looking at the arrangement of viscera in the gut. So most of the cases, the atrial arrangement will also follow the visceral situs. Very, very rarely you may find that atrial situs is different from the visceral situs, which means that when we say the situs is normal, that is, a person has liver which is onto the right side, a stomach which is onto the left side, and there is a spleen, and the bowel is arranged in a certain manner. So we have three different types of situs: situs solitus, or usual or the normal situs, because majority of us have what we call as a normal situs or situs solitus, so it comes to get labeled as normal situs. But we also have very few uncommon is situs inversus, or the mirror image. Mirror image is exactly opposite of what is seen in the situs solitus. And the third will be the situs ambiguous. Situs ambiguous is when you cannot determine whether it is situs solitus or inversus. It again gets divided into two parts: left atrial isomerism or isomerism of the left atrial appendage, and isomerism of the right atrial appendage. I'll come to this in a moment. So this is what a situs solitus or a usual situs looks like. You have a left-sided lung, you have a right-sided lung which is three-part, you have a spleen on one side, stomach and liver. They are all arranged in a normal fashion. What we say is normal. Mirror image is opposite of this, and so are the atria. So we said that atria are to be identified by their unique feature, which happens to be the atrial appendage. So left atrial appendage is like a thin finger-like projection, and whereas the right atrial appendage is a broader appendage. So here we have a reversal of the picture. But what happens in situs ambiguous? You could have right atrial isomerism or left atrial isomerism. Now how does that affect? Let's talk of the right atrial isomerism. That means the entire body structures or the arrangement is right-sided arrangement. So right-sided arrangement means both the sides of the lungs will have three lobes, trilobe bronchus and a midline liver. Similarly, left atrial isomerism will have two lobes on either side. The bronchi are long and the liver is again midline because it doesn't know where to go, and polysplenia. How does that affect? How does this affect cardiac structure? Because if we are saying this is right atrial isomerism, that means both the atria are similar to right atrium, then IVC will be normal, but where do the pulmonary veins go? Or where does the SA node appear? This atrium or this atrium? Similarly, left atrial isomerism, IVC will not have any place to go because both the atria are left-sided atria. So these make a big difference because then the abnormalities are becoming more complicated. So a right atrial isomerism, I'll go on, I'll explain in a while. These are a couple of videos which I recorded. So if you can see here, this is what we see as a first subcostal picture, is a situs solitus. This structure here is a pulsatile structure, and this is the IVC, and majority of the liver you can see is on the right side of the screen, whereas this is a situs inversus. Majority of liver is on the left of the screen, aorta is towards the right, and this is the IVC here. So just as blood vessels are opposite in situs inversus, so are the atria. For those who can recognize, this is the left atrium, morphological left atrium. You can see the attachment of pulmonary veins and you can see a part of the left atrial appendage, and this is more like a right atrium. So when we have situs ambiguous, as I said, two right-sided lungs, two left-sided lungs, either way. So if we have isomerism of the right atrial appendage, what we are going to see is two right-sided lungs, a midline liver, a complex form of AVSD with a right ventricular dominance. Since both the atria are going to be similar to right-sided, so these patients will often have a TAPVC. There will be a bilateral superior vena cava and agenesis of the spleen. And there may be two SA nodes in these patients, and each node may show a different pattern on ECG, and they may work alternately, sometimes one node, sometimes another, and we have seen these patients who have fast heart rates with one node and slow heart rates with other. Whereas in IVC, whereas in left atrial isomerism, we have features of IVC interruption. So the hepatic portion of IVC is not there. There are two left-sided lungs, there is a midline liver, pulmonary veins tend to drain on both the atria, ipsilateral drainage, multiple spleens, and usually we have simpler defects such as ASDs, PAPVCs, etc. And there is a diminutive SA node or a SA node sling. A video to show the situs ambiguous along with. So midline aorta, you can see this is the midline aorta here. And you can see here is a IVC interruption. This blue channel is ascending upwards. It doesn't drain into the liver. It crosses the midline and continues upwards to become azygous or hemiazygous vein, as the case may be. So following the situs, we know the next structure is what we say is cardiac axis. Cardiac axis means where the heart is located. So is it usually what we say is situs solitus levocardia. Levocardia means majority of the cardiac mass is in the left of the hemithorax. Situs inversus corresponds more or less to dextrocardia, or heart is on the right. But whenever and usually in these cases we have simpler abnormalities such as ASDs, VSDs, TOF, etc. But whenever the situs and the cardiac axis do not correspond with each other, usually there will be complex kind of abnormalities such as CCTGs, unbalanced AVSDs, etc. So these are the important factors. When one starts looking at situs, one has to see, okay, fine, this is situs inversus or situs solitus, and this will be what kind of arrangement that I am going to see in the body. So by definition, levocardia just means cardiac mass in the left hemithorax, dextrocardia, right hemithorax, mesocardia, the heart lies in midline. We do not use these terms anymore, dextroposition and dextroversion. Dextroposition was heart shifted to the right secondary to any thoracic region such as, diaphragmatic hernia, etc. Whereas dextroversion was situs solitus with heart on the right. So these two terms are not used anymore. In our descriptions, we use only first three terms. Then second step is identification of systemic and pulmonary venous drainage. For systemic venous drainage, we say that superior vena cava and inferior vena cava are connected to right-sided atrium. Whereas IVC is more consistent, SVC may be bilateral, pulmonary veins typically drain into LA, may be anomalous. So anomalous pulmonary vein can be into SVC, TAPVC of CS, to RA, etc. Normal situs solitus with normal pulmonary and systemic venous drainage. You can see the SVC coming from above, while IVC connects down. Then comes the AV connection. The left-sided AV valve is called the mitral valve, the tricuspid valve, and then we have the common AV valve. The connections may be concordant or the normal connections, discordant as in CCTGA, and univentricular connections such as tricuspid atresia or DILV. Just showing normal connections here. Mitral, LV, LA, tricuspid valve, RA, RV. As we say, there is usually offsetting, but this offsetting again may be lost if patient has a big inlet VSD, but still mitral valve is mitral valve because it is not attached to the septum usually. And there is no offsetting when we are dealing with a patient with AV canal. There is no offsetting, and usually we have is a common AV valve. Discordant atrioventricular connection. The right atrium gets connected to LV and the left atrium gets connected to RV. You can see the left atrium, the right ventricle, because this has a moderator band here. This is a smoother looking ventricle, can be identified by its shape, and this is the right atrium. Connections are discordant. Common connect AV valve, where we have a AVSD, univentricular AV connections. Univentricular AV connections mean that either one of the connection is absent, just as in this case, the right-sided connection is atretic, whereas left side opens into the left ventricle. So this is tricuspid atresia. This is another picture where tricuspid valve is atretic, but this is absent connection, and this is imperforate valve. Again, one of the forms of univentricular AV connections, where the common AV valve can be seen opening predominantly on this chamber. And now if you look at the morphology of this chamber, this is the right ventricle here because it has a moderator band, and here This is the left ventricle. So again a univentricular connection because of the attachment of the leaflets. Step 4 will be identification of the ventricular loop, whether it is a D loop ventricle or a L loop ventricle. D loop ventricle is a normal kind of position where if you put your hand in the tricuspid annulus, then the fingers will point towards the pulmonary annulus. So that's what is called the D loop, and the reverse is called the L loop. So D loop is more for normal hearts, whereas L loop is for CTGS or AV discordant connections. Step 4 will be identification of ventriculo-arterial connections. So ventriculo-arterial connections could be concordant or discordant. Discordant will be RV to aorta and LV to PA. You could have a single outlet. Single outlet means a aorta or a pulmonary valve is atretic, or a common outlet. Common outlet will be truncus arteriosus. Some of the pictures showing normally related great arteries. Now this kind of sweep that the pulmonary artery goes around the aorta can only happen in the normally related great vessels, where all the three connections are concordant. The pulmonary arteries may or may not be in normal relation, and this is the kind of pattern that you would get, we call as a D Malpose great vessels, where the aorta comes to the right and this is the pulmonary artery here. You can see the pulmonary artery bifurcation. So this is the kind of picture you will get as a transposition of great vessels. L Malpose great vessels, a characteristic feature of CTGS, but not 100%. Here you have the aorta on the left and pulmonary artery is posterior. So left anterior aorta and posterior pulmonary artery is L Malpose great vessels, usually associated with congenitally corrected transposition of great arteries, but may be associated even with normal hearts. We have seen these kind of arrangements. A concept of anterior and posterior deviation of outlet septum. So I'm going to need a few more minutes. Anterior and posterior outlet deviation of septum. Anterior deviation of outlet septum usually will cause subpulmonic obstruction, such as we see in tetralogy of Fellow, and posterior deviation of outlet septum usually is associated with subaortic obstruction or subpulmonic obstruction in case of transposition. So just a video. That's the aorta. Sorry, the loops are not playing well, but you can see this is the anterior deviation of outlet septum. This is the outlet septum here. That's the pulmonary valve, and that is the subpulmonic obstruction here. So that's a hallmark of tetralogy of Fellow. And the posterior deviation of outlet septum, this is the interventricular septum, and that's the outlet septum here, and this vessel here happens to be aorta. So this patient has subaortic obstruction because of this posterior deviation of outlet septum. Now the thing is that if we find this picture, a patient with VSD has a posterior deviation of outlet septum, we have to look at the aortic arch, because most likely this child will have a coarctation of aorta or various forms of arch interruptions. Now a concept of double outlet ventricles. Double outlet ventricle is one artery plus more than 50% of the other artery. So if any vessel originates more than 50%, that is 51% of right ventricle and 49% into the left, but the other vessel is completely in the right side, then it becomes double outlet of the right ventricle. So we can have double outlet right ventricles, sometimes double outlet of left ventricle. That is more, DORVs are more common in nature. Double outlet right ventricle, should you have aortomitral discontinuity? If we go by the just 50% rule, then aortomitral discontinuity is not important. Whereas if you read Van Prav's article, then they say that aortomitral discontinuity is hallmark of double outlet right ventricle. But in many hearts, even the blood vessels are normally related. There is less than 50% override, aortomitral discontinuity may be present. So double outlet right ventricle behaves in multiple fashions, or there are various subtypes. You can have a double outlet right ventricles with normally related great arteries, which behaves like a ventricular septal defect. Patients are pink. All needs is a VSD closure. DORV, demalpose great arteries, is more like a transposition of great arteries with VSD, and DORV, L-malpose great vessels will require VSD closure plus RV to PA conduit. And that's how the management changes with just different orientation of the blood vessels. What I wanted to talk about, show about the aortomitral continuity. You can see here, this is the mitral valve and that's the aortic annulus, and they are cut in continuous, there is a fibrous continuity between mitral and the aorta. Whereas you look at this image, this is the aortic valve here and the mitral valve is here, and there is this interposition tissue or muscle between the two, and that's what is aortomitral discontinuity, which may be seen in normal hearts, but here we have the double outlet right ventricle because aorta is committed predominantly into the right ventricle. Again, another form of DORV, aortic override, more than 50%. Here, aorta is 100% into the right ventricle in this cartoon here. And we also have a smaller VSD here, aorta predominantly into the right ventricle. Just as we had double outlet ventricles, we can also have double inlet ventricles. Both the inflows are committed. Again, we follow the 50% rule, and we have DILVs and DIRVs. DILV becomes more common. DIRVs are very, very rare in nature. So when we have unequal chambers, because if one of the chamber is going to receive majority of the blood flow, then the other chamber is going to remain hypoplastic. So whenever one chamber is hypoplastic, then we have to name or identify the chamber based on its unique criteria, just as I told earlier. The left ventricle remains smooth-walled and the right ventricle remains coarse. Hypoplastic ventricle, if you look at the short axis, will always be in the posterior part of the ventricle mass and vice versa. Mitral valve and semilunar valve continuity almost always is present if there is a left ventricle. Very rarely there may be a half and half ventricle where half side will be LV and half will be RV, or a ventricle of indeterminate morphology. Just showing few pictures here. Yeah, if you look at this image here, this loop, you can see a smaller chamber here and a bigger chamber here. If you carefully look at the bigger chamber, it has a moderator band. So this is a patient with double inlet of the right ventricle, and same thing if you can see on the short axis, the smaller chamber appears posteriorly. So this is a smaller chamber which is a hypoplastic left ventricle. Another double inlet ventricle here. The bigger chamber is smooth walled chamber, and the smaller chamber appears anteriorly. So we can say that this is a double inlet of the left ventricle because the smaller chamber is anterior and it happens to the right ventricle. Unbalanced ventricles, again, one when the ventricle is hypoplastic, the other ventricle remains big, and we can identify the chambers based on their unique morphology. This is a common AV valve here, the moderator band, inlet VSD, and a smooth left ventricle here and a smooth ventricle here. So these are unbalanced AVSDs, and each one have to be managed in their own fashion, because if we have an unbalanced canal with a right ventricle dominance, then these patients usually tend to have a poor prognosis. In conclusion, sequential segmental analysis is a keystone in analyzing any patient with congenital heart disease. Each of the cardiac segments should be identified separately on the basis of its unique identification criteria rather than on the basis of its relation to any other structure which may be variable. Wherever possible, lesion must be described rather than using fixed terminology like DTGA or LTGA. It helps in creating uniformity of reports, planning of treatment, also in prognostication. Thank you.